Hello, and welcome to the Deciphering Clinical Education Oncology Podcast. I'm your host, Mandy Murph. Today's episode features Dr. Hanny Al-Samkari from the Massachusetts General Hospital and Harvard Medical School. He will discuss key findings from 5 studies in non-malignant hematologic disorders presented at the 2025 ASH annual meeting, including perspectives on the clinical implications of the data from these studies for patients with ITP, VWD, and iron-deficient anemia during acute infections. This episode is part of a larger educational program titled Bridging Discoveries to Practice, CCO's Conference to Clinic Highlights from the 2025 ASH annual meeting. For more information on Dr. Al-Samkari, along with a link to the larger educational program, please visit the show notes for this episode. And now, let's get started and hear what Dr. Samkari has to say.
One of the late-breaking abstracts at ASH this year, which I had the pleasure of presenting myself, was the VEHIT-2 study, which was a randomized, double-blind, phase 3 trial of ianalumab plus eltrombopag versus placebo plus eltrombopag in patients with primary immune thrombocytopenia, or ITP, who failed first-line corticosteroid treatment. All right, so what is ianalumab? Ianalumab is a novel antibody, a novel monoclonal antibody directed against the BAFF receptor. BAFF is critically important. It's a cytokine that's critically important in the maturation, differentiation, and survival of B cells. And that includes the autoreactive B cells that drive ITP. This drug is being evaluated in a number of different autoimmune diseases, and they've already published some positive findings in Sjogren's syndrome. There's trials going on in lupus, and it's being evaluated in autoimmune cytopenias, in particular ITP in the VEHIT-1, VEHIT-2, and VEHIT-3 studies, as well as autoimmune hemolytic anemia in the VEH-IA study. All right, and VEHIT-2 is a pivotal phase 3 study that asks the question, if we add this potent monoclonal antibody ianalumab to standard of care eltrombopag in people who have just failed their first-line corticosteroids, can we give patients a nice, stable, durable duration off of any therapy? Can we do that safely? And if we intervene early, before the disease becomes very immunologically complex, and we know that ITP becomes more complex from an immunologic standpoint the longer people have it. People develop oligoclonal T cell clones, for example, that drive refractoriness. If we give this very potent drug early, can we modify the course of the disease? In some fraction of patients, can we defang ITP? Can we take people who would otherwise have chronic relapsing disease course where they have crashes over time, very typical course of ITP, and can we turn that into a mild sort of ITP, which is a lab abnormality of mildly reduced platelets without any significant crashes, or at least much less likelihood of having a significant crash. And so this study looked at all of those things. And the key findings of the study were that, yes, adding ianalumab to standard of care eltrombopag, whether it's a high dose or low dose of ianalumab, did prolong the time to treatment failure in people with ITP. And this study used a novel endpoint called time to treatment failure, or TTF, which was the time from randomization until the first occurrence of any of the following: platelet counts less than 30,000, use of rescue therapy beyond 8 weeks of randomization, start of new ITP therapy at any time, and inability to taper or discontinue eltrombopag, or death. And all of the patients in this study were treated with eltrombopag, but they were required to taper off of eltrombopag by the end of month 6. And so patients received 4 infusions of study drug, either ianalumab 9 milligram per kilogram, 3 milligram per kilogram, higher versus lower dose, or placebo during the first 4 months. These are given once every 4 weeks. And the study showed that the time to treatment failure was significantly, both statistically significantly and clinically significantly prolonged in people receiving either high or low dose ianalumab versus placebo. And the drug did this without any significant safety signals, the most common treatment-related adverse event was neutropenia, which was very transient, lasting literally days to perhaps a week or two. Okay, this was very short duration neutropenia. And most importantly, the fact that this drug is immunosuppressive in and of itself did not lead to any increase in the rate or severity of infections during the treatment period or the post-treatment period. And this study's following patients for a long time. It's actually following patients for over 3 years from the time the last patient is randomized. The median follow-up at this primary analysis was between 11 and 13 months per group. So pretty good duration of follow-up now, but the study will continue to follow patients. So, of the goals of the study, giving people a nice duration off therapy without the need for a chronic controller therapy, that goal was met. Doing it safely, that goal was met. The third goal, this would be really groundbreaking in ITP because we have no disease modifying therapies, would be true disease modification. And we're going to find out how disease modifying this drug really is over that long duration of follow-up. Ianalumab is being evaluated in ITP in a number of different clinical trials. This is VAHIT-2. VAHIT-1 is a similar study, but looking at patients in the first line in combination with corticosteroids rather than in the second line in combination with eltrombopag. So truly newly diagnosed patients that have just been treated in VAHIT-1. And VAHIT-3, which is already reported out, is looking at ianalumab by itself, or some patients could enter that study with chronic low-dose steroid or low-dose or a stable dose of TPO-RA. In VAHIT-3, that was a study that already read out. This was in relapse refractory patients, third line and beyond. It was a phase 2 study, so a non-randomized study. And that study showed that the drug was also safe and effective in that population of patients. And actually, one of the other abstracts presented at ASH this year was a follow-on analyses from the VAHIT-3 study, and this was presented by Dr. Phil Choi. And this study was really interesting in that it just showed the results of many of the secondary endpoints and subgroup analyses. And there wasn't a specific population of patients, right, that was very clearly lacked response to ianalumab in this study and subgroup analyses. The time to confirmed response in patients who achieved a confirmed response to ianalumab in this study was a few weeks. Rates of bleeding events and their severity improved in patients over time over additional follow-up. The B-cell depletion induced by ianalumab in the study was rapid and profound. And similar to what was seen in VAHIT-2, the level of IgG dropping was actually very minimal, which is very reassuring when it comes to use of an immunosuppressive drug and maintaining your responses to various vaccines that the patient has already received. There were no severe infections observed in the VAHIT-3 study, except for a grade 3 event of Clostridium difficile infection reported as not related to ianalumab by the investigator. This gives additional supportive evidence for this drug in ITP. If VAHIT-1 is similarly a successful positive study, then we may be seeing ianalumab added to our ITP therapeutic armamentarium and potentially in ways that disrupt the treatment paradigm, right? Addition to corticosteroids in the first line or addition to eltrombopag in the second line. Now I'm going to talk about another abstract, also in ITP, but in a distinct subtype of ITP. So this is immune checkpoint inhibitor induced ITP or ICI ITP. All right, so this is a very problematic entity that we see in patients with cancer receiving immune checkpoint inhibitors, which are obviously a mainstay of cancer therapy now. There are multiple different classes, CTLA-4 inhibitors, PD-1 inhibitors, PD-L1 inhibitors, LAG-3 inhibitors, and there are now 12 immune checkpoint inhibitors approved in the US for treatment of over 20 cancer types. But one of the things we know happens with these drugs is immune-related adverse events, or IRAEs. And immune-related adverse events, while they normally target skin, GI tract, and endocrine glands, they certainly can target blood cells. And so we can see autoimmune hemolytic anemia, we can see ITP, We can see autoimmune neutropenia, aplastic anemia, pure red cell aplasia, right? These are all potentially possible. But we don't have very much data, at least before this study, we didn't really know what the rate of ICI-ITP was in all patients receiving immune checkpoint inhibitors. We didn't know much about how it responded to therapy. The prior data was in very small groups of patients, smaller case series. This was an observational study conducted over 7 different large academic centers, including many, many hospitals. And so it found that the incidence of ICI-ITP was 0.25% of all patients receiving immune checkpoint blockade, or 1 in 400 patients. All right, so not hugely common, but also not all that vanishingly rare. 3/4 of patients who developed ICI-ITP did recover from the ICI-ITP, usually after treatment with glucocorticoids, IVIG, and/or thrombopoietin receptor agonists, with similar response rates despite the choice of therapeutic, around 60% response for any of these therapeutics. This study included over 200 patients with ICI-ITP, which is far greater than any of the other studies evaluated before. People ask, can you re-challenge a patient with an immune checkpoint inhibitor after they developed ICI-ITP? You can, and doing so results in recurrent ICI-ITP in about 30% of patients in this study. But of those patients that were re-challenged, again, about 3/4 recovered after the second round of treatment. And ICI-ITP and its severity were independently associated with a higher risk of death. The worse your ICI-ITP, the higher your likelihood of death. And this was an independent predictor in evaluation in a multivariable analysis. This is important for oncologists and hematologists who are referred patients with ICI-ITP. Now I'm happy to talk about abstract 308, which is a study of a novel protein S antibody in patients with von Willebrand disease. This drug is called VGA-039. And so this is a subcutaneous every 4-week maintenance drug, similar to emicizumab in hemophilia, given subcutaneously on an every so many week basis. And this was a phase 1/2 multidose study of this anti-protein S antibody in von Willebrand disease. Why might a protein S inhibitor be good in von Willebrand disease? It enhances thrombin generation to restore hemostasis in patients that have a deficiency of a critical coagulation factor, von Willebrand factor, right? So this drug, in theory, could be effective in multiple different bleeding disorders. The first bleeding disorder that's being evaluated in substantial effort is von Willebrand disease in the VIVID-1 and VIVID-2 studies. VIVID-1 was healthy volunteers, and VIVID-2 was patients with von Willebrand disease, all types represented. And then VIVID-3 was the study that was presented at ASH, and this was an open-label phase 1/2 study of multiple doses of subcutaneous VGA-039. This study enrolled 16 participants, of whom 8 had completed dosing and were reported on efficacy-wise, and 8 were ongoing. And so safety was reported in all patients. Efficacy was reported in the patients that had completed dosing. No patients had withdrawn on therapy. There were no thromboembolic events, no injection site reactions, no concerns about increased D-dimer, no concerns about any really significant thromboembolic predisposition from this early study, with rather substantial improvements in the annualized bleeding rates after treatment with VGA-039, like 75% in some patients, really substantial improvements, including in those that were previously receiving recombinant von Willebrand factor as prophylaxis, given via intravenous infusion once to twice a week, right? So this is a subcutaneous drug given once every 4 months. So this drug is promising in von Willebrand disease. The phase 3 study of this drug in VWD is currently enrolling. We'll look forward to seeing the final results from this study, VIVID-3, the phase 1/2, and hopefully this will provide a nice prophylactic maintenance option for people with von Willebrand disease. Lastly, I'm going to talk about one of the plenary abstracts. This is abstract 5, and it was called Deciphering the Dilemma, Intravenous Iron Use in Iron Deficiency During Acute Infections. This is presented by Dr. Sohail. And one of the things that many of us recognize is that people have anxiety about giving intravenous iron in hospitalized people with infections because they're worried that the iron, quote unquote, feeds the infection or feeds the bacteria. Many bacteria are siderophilic. They like situations of high iron. This has really influenced hospital policies and influenced providers to not give intravenous iron. And this study that was presented as one of the plenaries was a very large study using the TriNetX research network, a global federated EHR network with de-identified data from 275 million patients across the world, updated every 2 to 4 weeks, providing aggregate real-time counts and built-in analytics. Right? This was a more sophisticated large database study, effectively. And the results were relatively striking. Basically, it didn't matter what the type of infection was. People receiving IV iron had better survival than people not receiving IV iron. They had better survival. They had lower rates of requiring red cell transfusion, which not a surprise, right? But MRSA bacteremia, pneumonia, urinary tract infection, colitis, cellulitis. I mean, it was many different infection types. It didn't really matter. The hemoglobin improved, not a surprise. The amount of red cell transfusion required went down, but survival improved, right? I have never had any personal concerns about using intravenous iron. I've always called it a urban legend to use intravenous iron in patients with active infections. Obviously, blood contains plenty of iron, and giving people blood transfusions is also immunosuppressive. So I'd much rather give people IV iron. But it's really nice to have a big study and a study presented as a plenary at ASH that reinforces this and that gives us good data to say, no, in fact, it is totally fine to use intravenous iron. In fact, it may be beneficial to use intravenous iron to treat anemia and iron deficiency anemia in these patients.
Thank you, Dr. Al-Samkari, and many thanks to you, our listeners, for joining us. As a reminder, to view the full program, Bridging Discoveries to Practice, CCO's Conference to Clinic highlights from the 2025 ASH annual meeting, please click on the link in the show notes. And be sure to check back regularly for more episodes on important hematology topics.